Thank you for joining me today. Today what we're going to cover is the Rose K2 XL corneal scleral lens and basically how to fit beyond the limbus. So there are some corneal irregularities that are just about impossible to fit with a cornea or intralimbal design. For example, a very descented keratoconus, a pellucid where the steepening is very inferior. Some surgical techniques like rings are very difficult to fit with a corneal lens and get stability. And globus, where you have such a high sagittal height, it's just about impossible to get a lens to center on a cornea with a corneal lens. Just before we start, I just want to make sure we're all on the same page with our terminology. So when I refer to a corneal scleral lens, I'm referring to a lens with shared bearing on the cornea and the sclera. When I refer to a scleral lens, I'm referring to bearing all on the sclera or on the conjunctiva, so it completely vaults the cornea. And corneal scleral lenses have limited tear reserve because you get some tear exchange, whereas scleral lenses you get very little tear exchange and you have almost unlimited tear reserve capacity. My philosophy, I go to lectures and I listen to people talking about scleral lenses, and one of the first things they say is that you must not touch the cornea with a scleral lens. That is true if the lens doesn't move and you don't have tear exchange, but just remember, we've successfully rested lenses on the cornea for many years now and got very good results. We know corneal lenses have very low infection rates and a very high degree of success. So why the sudden need in semi-sclerals to completely vault the cornea? As long as the lens has tear exchange and moves, there is no need or no problem to actually completely vault onto the conjunctiva. And it's quite okay to touch the cornea, as you see here, where the lens actually rests just inside the limbus. So my challenge was to design a lens based on a normal GP fittings principle that's easy to use and follows my 5-step fitting system. So here's my philosophy. Basically 20 to 30 microns clearance over the limbus. That will often show as touch, as feather touch, but you actually do have a slight clearance. You have a landing zone less than 1 millimeter wide just inside the limbus. You have a clearance over the highest point on the cornea. So in keratoconus, that's either central or slightly inferior central. And then you go out parallel from the limbus out to the edge of the lens, where you have about 50 to 60 microns of corneal flush, so that the tears can flush right up to those limbal cells. What are primary indications for a semi-scleral lens? The ones that are listed on the right here are certainly a primary indication. Corneal, repeated corneal lens intolerance, because they're so much more comfortable initially, you often get around that. Pellucid is an absolutely ideal condition because of the very low inferior steepening, just about impossible to fit with a corneal lens. Post rings and globus. But all the other ones here also are very useful, including for severe dry eye, where you want to trap some tears behind the lens and keep the cornea bathed in the tear layer. And where everything else fails, where you've tried everything, you haven't got a successful lens, they certainly are a problem-solving lens. If you look at these conditions here, it's very difficult to get a corneal lens to center and to be stable on a cornea. This lens, as soon as the patient looks sideways, there's so much asymmetry in that cornea, the lens will move off. Here we have a high degree of astigmatism. We may be able to get that right with the corneal lens, but it would be a challenge. And this is pellucid, where you have to misfit it to get the lens to center. If you try to center and fit this part of the eye, the lens will descend down. Also, we've got a lid structure that makes a corneal lens to center down, as you see here. Sometimes it's very difficult, no matter what you do, increasing the diameter, increasing the edge lift, will not make that lens center. By going to a semi-scleral lens, such as a corneal lens, Rose K2 XL, you can see how much better the centration immediately becomes, and it's not an issue. Also, here is a lens that doesn't look too bad. This is the post-graft design, but as soon as the patient looks sideways, it moves off the cornea. So even though you've got a relatively good fit in the primary gaze, as soon as you look obliquely, the lens is not stable. So this is my 5-step fitting system, which I'm sure if you fit my designs, you're very, very aware of. We always start with the central fit or the base curve. When we talk about the central fit, just remember what we might be looking at may not be central. It may be paracentral, or in pellucid, it will be down at 270. So we really should call central fit base curve because that's what we're addressing here. The guide to the first trial lens is based on mean Ks, and you can see here for keratoconus and for corneal rings, there's a special guide, which I'll show you in the next slide. And for pellucid grafts, you have to go steeper than the mean Ks, and also for globus. So this is a guide which is based on that central 3 millimeters. It can't be always accurate, it's just a first starting point. So you basically judge the initial clearance over that highest point on the cornea immediately after insertion. Once you have it correct, you reassess it after another 20 minutes. Any staining and subsequent checks when the patient comes back, if you see any staining at the highest point on the cornea, you know you need to go steeper. And here's the keratoconus and also the guide for corneal rings. For example, if we had a mean K of 6.6, that would be an indicated first trial lens of 7.0. For very, very early cones, you can see we have to go actually steeper than the mean K. And for very advanced cones, let's say at 5.0, we have to go significantly flatter than the mean K. So you fill the bowl with non-preserved saline. Don't be afraid to put a lot of fluorescent in. You can't over-fluorescent it, so don't be afraid. People put too little in, you don't get enough fluorescence. There are different methods. Personally, I prefer to use a suction holder. It controls the lens better. I find using the tripod method that my hands get in the way of the eye and I can't see the lens when it touches the eye. So for all my workshops and for my patients, I prefer to use a suction holder. It's a big wide one. I cut the bottom off it so it actually doesn't suck the lens on, so that when the lens touches onto the eye, it immediate releases. The lens will sit quite nicely on top of that large suction holder. So for initially, you can judge the fluorescent immediately when the lens goes in. You don't have to wait. And then, as I said, after 20 minutes, once you've got it right, you look at it again. In this case here, this is a keratoconic. You can see it is very slightly flat. What I'm aiming to do is to get the flattest base curve that shows no touch. And I'll show you some more slides on that in a moment. Once we have achieved that, you will have around about a 30 to 50 micron clearance over that highest point on the cornea. I used to talk about feather touch, but unfortunately practitioners' interpretation of feather touch varied dramatically. So I now talk about the flattest base that clears the highest point on the cornea. Pellucid, where's the highest point? It's down here. Again, this is slightly flat by about 0.1 of a millimeter. So keratoconus, you're going to judge it at the apex of the cone. For a graft, invariably the highest point is along the interface of the host donor tissue. So it is imperative that the fit does not show bearing at the highest point on the cornea, otherwise corneal staining, rocking, lift off, and the edge will lift off, often introducing bubbles at that point, and discomfort may result. If you're unsure about whether you're steep enough, you're better going a little bit steeper than a little bit flatter. A flat lens will cause staining at that highest point and will also reduce the movement significantly. So here you can see this is a rings implant. This is okay to being a little bit flat. Landing zone is good. We've got a nice landing zone, less than 1 millimeter within the limbus. If you need additional fluorescent after you put the lens in, if that's flushed out, you can add it to the conjunctiva and simply a few blinks and you should see the fluorescent flush underneath the lens, as you can see here. These are all too steep. We can see this is obviously more than the clearance we want. We're looking for a maximum of 50 microns over that steepest point. These are obviously too flat. These would cause problems. You can see the staining already starting to occur here. This would stain over the rings and be most uncomfortable. And this graft, which has a fair amount of with the rule astigmatism, would also cause staining over these bearing points here. We need to go steeper. So remember the goal, the flattest base curve that shows no touch at the highest point in the cornea. And we look at these pictures, they're all about 0.1 flat. Slight touch here, slight touch here, and here, and here. If I showed you the correct fit, of course, they would all look exactly the same. So the only way I can illustrate it to you is to show you a lens that's slightly flatter than the optimum fit. What about the peripheral fit? So the second step in my fitting system is the peripheral fit, and what we're trying to achieve is a fluorescent flush under the peripheral band 0.8 to 1 millimeters wide at the edge. So basically from the limbus out to the edge of the lens, we want to see fluorescent. You have to observe it immediately after fluorescent is installed. Otherwise, it flushes out within a minute or two, and it will make this area look tight. So if you can't judge it immediately, then you need to reapply fluorescent. What you're aiming to achieve is to be able to see the conjunctival vessels through the fluorescent here. If the edge lift is too high, as it is here, you'll start to see the actual conjunctival vessels be less visible. So you can see that they're nicely visible here and here. So if there's insufficient fluorescent, you increase the lift. Excessive fluorescent, you decrease the lift. And there may be, you've got to go right around the clock for this particular lens design, like it is with any semi-scleral lens design. And there may be some asymmetry in the edge profile around the clock as you look around the lens. One thing to remember, if you do change the edge lift with XL, it does not change the central fit. So you don't have to think about making any adjustment to the central fit when you change the edge lift. So looking at these peripheral fits, although they vary a little bit, they're all okay. And you may see, as you go around, a lens being a little bit tighter in some places than others. That is fine. You don't have to get it perfect everywhere. As long as you're not getting bubbles introduced underneath the edge anywhere around the clock, and as long as there's no staining at any point where the lens is too tight, these patterns are quite acceptable. You don't have to get perfect symmetry completely around the clock. So you have, like all my designs, a range of edge lift values. All these pictures are with the standard lift lens. So if you put the lens in and you see this is ideal, you would simply order a 0 or a standard lift. This is getting a little bit tight. You can see that black ring starting to appear at the edge of the lens. You'd order a +1 or a standard increase lift. And in this picture, you can see there's absolutely no fluorescent getting underneath the edge of this lens here. You'd have to order a +2. Similarly down here, these are getting too open. You're going to have to close the lift down by ordering decreased lifts. And often when the lift is too high, you'll start to see small bubbles appear around somewhere around the edge of the lens. You have 13 edge lift options that you can choose from. The standard ones go in 1 steps, but you do have half diopter steps or half the steps between those, so you can order a 0.5 or a 1.5 increased if you need to fine tune it any further. These lifts are getting too excessive. You can see it's too open. We can't see the vessels here, and we're starting to see these bubbles introduced underneath the edge of the lens. Here we have not got sufficient edge lift. You can see this is impacting on the conjunctiva here and here. And here we don't have any significant amount of fluorescein underneath the edge of the lens. It takes a while to get used to the lens system and the edgeless system, but once you start to use it, you'll understand how to vary it to get the perfect pattern underneath the edge of the lens. One other useful tip is using the push-up or push-down test to see how easily fluorescein enters underneath the edge of the lens. You simply place fluorescein in the eye, you then bring the lower lid up, pushing the tear layer in front of it, and you should see the tears flush underneath the edge of the lens easily as you do here. You can either do it superiorly or inferiorly. I usually use the push-up test and just see how easy the tears enter underneath the edge of the lens. This is too tight, I'm pushing this up. You can't see the tears really entering here. And again, here we're getting some tears, but I'm using a lot of pressure. This is definitely too tight. Both these lenses would bind to the cornea. Excuse me. So judging the correct edge lift is probably the most difficult part of the lens to get right. It will take some experience, and there's several factors you need to consider. The fluorescein pattern, which we've already talked about, the movement, which I'll talk about in a moment, the comfort. If you put a lens in and the patient says, that is so comfortable, I can't feel it, you probably have a tight edge lift. So the tighter the edge lift, the initial comfort is greater. The looser, the initial comfort is not as good. So that gives you an indication of just, when you put this lens in, the patient should say, yep, I feel it a bit, but it's not too bad at all. I've got some sensation about the same as a soft lens. How easy the lens is to remove, and I'll show you that in a moment, and we've talked about how easily the fluorescein enters underneath the edge of the lens with the push-up or push-down test. Remember, when you're removing the lens, never put the plunger on the center of the lens. If you do, the forces will just basically be required to pull it out a huge. Always put the plunger on the edge of the lens, as you can see here. The lens should come out smoothly, you can see here in this video, without excessive force. If your base curve is too flat or your edge lift is too tight, you will find that you require extra force to get that lens out. Next to the third step, the overall diameter. The 14.6 diameter, which is my standard diameter, is basically for a standard cornea of 11.8 millimeters, which is the average for the world. So for very large corneas, you need to make the lens bigger. For small corneas, you make the lens smaller. And you're basically trying to get a lap outside of the cornea about 1.3 to 1.5 millimeters. So that's what you should see, very similar actually to a soft lens. This is okay to getting a little bit large. If you're in doubt, you're better to leave it bigger than smaller. You get into less trouble with a slightly large lens than a small lens. Here you can see this is less than 1 millimeter here. When the patient blinks, they will feel the edge of that lens, and also we may get, if the lens moves at all, bubbles entering at this point. So we would need to increase the diameter here. Here's a graph here, and you can see the lens is centering up quite significantly. And again, the lens is too small. You'd have to increase the diameter by at least about 0.6 to 0.8 of a millimeter here. Again here, we do not have, this is less than 1 millimeter of lap outside of the limbus. The fourth step, the location. Fortunately, XL locates, like most semi-sclerals, very, very well. So decentration isn't usually a problem. However, if you have a very large oval cone descended down, it may cause the lens to descend down, as you see here. This is the edge of the lens here. How do you actually fix that? Making the lens flatter or larger will often help the lens to sit up and center correctly. Slight decentration doesn't seem to be a problem, so don't be worried. As long as you have, if it descends down, as long as you have sufficient lap at 12 o'clock, that nice at least a millimeter to 1.3 millimeters at least up here, and that is absolutely fine. And finally, lens movement. We don't normally talk about lens movement with semi-scleral lenses, but certainly with XL we do. When you first put the lens in, you should see about 0.5 of a millimeter, as you see here. I'd like to get the patient to look up and look at the movement at 6 o'clock here. You can see here, this is both of these videos an ideal amount of movement. Once the lens is settled down after 20 minutes, you should see just discernible movement, not excessive, just discernible movement. In this video, the movement is too great, and you have to shut this down. Excessive movement makes the lens less comfortable. The patient would feel this. And here we have a lens that's not moving at all. This is bound. This would be a very comfortable lens, but would not be good long term because we'd not get tear exchange underneath the lens, so we would have limited wearing time. So judge the movement. I prefer it at 6 o'clock, getting the patient to look up and blink. 0.5 on first blinking, and then once it settles, just discernible movement. To increase the movement, you increase the edge lift. That's exactly the same as a corneal lens, but the base curve is different. To increase the movement, you actually steepen the base curve, whereas in corneal lenses, to increase the movement, you would actually flatten it. So that is different, and to make the lens move more, if you make the lens smaller, it will also tend to move a little bit more. And exactly the opposite if you want to decrease the movement. I want to very briefly cover the asymmetric options for XL. There are many. There's about 150 different designs in the whole Rose K2 range once you look at all the options in the asymmetric options. Because once you get to these large diameter lenses, you often have toricity and asymmetry on the conjunctiva, which you have to address. You just can't ignore it. And you can see here the lens showing fluorescent flush here, but not here. Again, it's showing it here, but not here. Now, in some cases, this may not cause an issue. If it doesn't cause staining or bubbles underneath the lens or discomfort, you don't need to worry about it. But if it does cause any problems, then you have to address it. And certainly here we have so much asymmetry between this position on the clock and here. We would need to address that. So I've addressed that with several different designs, and the ones that I've highlighted in this pink color here are by far the most used. Quadrant specific edge lift, which I'll cover in a moment, toric periphery act and reverse act, where you can tuck the edge of the lens out instead of in. Segment specific act, where you actually restrict the act to a small quadrant. You can add front torics to any of these designs, and you actually can have a fallback surface toric, although fortunately with semi-scleral lenses, it's very rarely required. So in more detail, if you order a quadrant specific edge lift, you will change the fitting pattern outside of the limbus in the last 2 millimeters of the lens. So you can see here, nothing inside that red circle will change. The only thing that will change is the fitting pattern outside of that red circle, which is basically outside of the limbus. If you have a toric periphery, the only thing that remains the same is the fitting over the back optic zone in that central 8 to 9 millimeters. Everything outside of that will change, and we'll show you more detail in a moment on that. ACT, although we tend to talk about it in one quadrant, ACT actually affects 180 degrees of the lens, although the greatest effect is at the axis of the ACT. So let's go into that in more detail. Firstly, quadrant-specific edge lift. And as I mentioned, when you apply quadrant-specific edge lift, it's only going to affect the fit outside of the limbus, basically. You can choose to change the lift in any quadrant independently. So you can say, I want standard lift here, increased lift here, double decreased here, increased here. You can choose in each quadrant what lift that you require. And they don't need to be at 180 or 90. They can be oblique. So you, for example, you could order it at 30, and then the next quadrant would be at 120, etc., around the clock. And you can see here in this diagram here, we are too tight in this area here. The edge lift looks fine here, which is causing this injection in this particular quadrant. So what we do is we apply extra edge lift in this quadrant, axis 225 degrees, and immediately we open it up here and have a very, very good looking pattern, and we eliminate that injection. So for ordering, just state the axis of the center of the quadrant. So in this case, you have ordered the axis between 180 and 270 at axis at 225 degrees. What about toric periphery? Toric periphery, when you apply it, will change the fit outside of this central back optic. So the fit both on the peripheral cornea and outside the limbus will be changed. With a toric periphery, the standard is 1.2, although you have a range from 0.6 to 2.0. And with a standard toric periphery, it will be steep in 0.6 in this meridian. It will be flat in 0.6 in this meridian to give you that 1.2 difference in the two meridians. There's no need to state the axis of the flattest meridian at all. The lens will turn around nicely when you put it in. Even if you put this in 90 degrees off, the lens within a couple of blinks will go round to the correct position. And the laboratory will put the laser lines along the flattest axis so you can make sure that the toric periphery is centering and is stable. They usually center up very well, as you can see here. They usually don't move, so adding some front surface cylinder is usually very stable and you get very, very good visual results. Prism's not normally required. You can add it if you do have problems with centration, but it's not put in automatically at all. So here we have a case. This is my first case that I ever fitted a toric periphery, a patient of mine, where I basically guessed that it was 1.2 toricity. And I found, in fact, that I still had the bottom two open. The edge lift looks nice, so I was quite happy. When the patient came back, they were absolutely delighted. They'd worn corneal lenses and they said to me, this is the best, the most comfortable lens I've ever worn. I thought I can improve this further. I haven't got enough toricity here. I need to increase the toricity. So what I did was went to a 1.6 where I closed that down, thinking I had done a great job. And even though we still have tears circulating under here, he did not find this lens as comfortable as the previous lens. So it taught me a very good lesson that some misalignment to get tear exchange is quite desirable. You don't have to have perfect alignment around the clock. It's not necessary. And the ACT design, as I mentioned, when you apply the ACT, it actually affects a whole 180 degrees. You can have ACT in two quadrants, so you can say, look, I want to tuck the lens in here, but I also want to tuck the lens out here. So you could have ACT here, and you could have reverse ACT here, or anywhere around, as long as they're 90 degrees apart. ACT can often tighten the edge inferior, just be aware of that. So when you apply ACT, even though you talk about it in one quadrant, and it's normally at 270, it can affect the fit on the edge lift in this quadrant. And sometimes to compensate for that, you have to also increase the lift in these two quadrants because the lift ends up too tight. Just be aware of that. So you can see here, here's a lens with ACT. You can see how we're tucking the edge of the lens in. Remember, you can also tuck it out for things like pterygiums or where you have some elevation on the conjunctiva that you want to get over. You can have reverse ACT. These would be two ideal cases for ACT, where you get to lift alpha completely over the cornea at the edge of the lens. We want to tighten this fit up all around the clock, not up here. This is looking absolutely fine. So all we want to do is tighten the lens in this 180 degree arc from about here around to here. Again, this one is a perfect one for applying ACT. And this would require an ACT grade 2. The standard ACT is grade 2 ACT. So in some cases, the act will not center up. There is a base down prism of 1.25 put automatically into ACT. Most of the time that will locate the lens well, but as you can see in this case, where that laser line, which indicates the axis of the act, is moving around, if it doesn't locate, you can ask the laboratory to add extra prism and they'll tell you how much you need. So you can have prism at 270 and have the act axis at different. They don't both have to be exactly the same. So you can specify the prism and the ACT at different axes. So in summary, the XL design, same principle as fitting a corneal lens, no new learning curve, which makes it very easy to fit. You're basically judging the fit on fluorescent patterns, the same as you do with a corneal lens. You have better tear exchange. We don't normally talk about tear exchange with semi-scleral lenses, but certainly with this design, we want to get tear exchange. That's very important. It settles very quickly because we're not landing it on the conjunctiva, we're landing it on the cornea. The cornea only compresses 20 to 30 microns, so within 20 minutes, the lens is settled down. Whereas with semi-scleral lenses, which vault the cornea onto the conjunctiva, that settling can take hours, several hours, and the lens can settle up to 150 microns. And it has a very high decay because it's a thin lens, and also because we're using high decay materials such as a Menicon Z, we get a decay of around 81, which is about 4 times the decay of the Holden-Mertz criteria of 24. So again, you get excellent transmission of oxygen through the lens to the cornea. There's a lot there, I know, to take in one lecture, but however, on the Rose-K website, www.roseklens.com, if you go to the practitioners section, you will find there is plenty of information here, frequently asked questions on Excel and the fitting guides. If you go to the fitting guides, it will ask you for a password. The password is RK, PRAC, that stands for practitioner, RK-PRAC 07. If you forget that, the laboratory will be able to help you and assist you with that password. And here are all the fitting guides. You can see the XL semi-scleral guide is there. Also, we do have the special options guide, which goes into more detail about the special options available for the XL design. My sincere thanks to Menicon today and to you all for joining me. I do hope you find the lecture useful. XL is certainly a problem-solving lens for me, and when I'm challenged with very difficult corneas, it's my default lens. As Jennifer will support in our workshops around the world, we've used XL to solve some very, very difficult fittings. So thank you for joining me again, and I hope the rest of your day or your night goes well. Thank you very much.